Remember today, when we get done, you want to email Alabama EMS challenge@gmail.com. You get a link, you fill that out for your contact certificate, or you can follow the link that Chief Ward puts into the chat box today as well. Try to get those emails in by this afternoon so we can get this stuff out. Remember, Chief Ward and myself, we both have several jobs, and this is all free stuff. It sometimes takes a few days to get this back to you. So please be patient with us. And we're going to have live in-person people. This is great. I'm very excited. And I know this is wonderful. Sweet. All right. We are social distancing. All right. I'm not going to wear a mask. There's nobody on the front row. So we're saying, oh, thank you, ma'am. Oh, great. I just got burned. That's the story. And then I guess, all right. All right. Some updates for the region. Remember, protocols came out June 14th. If you have not had your protocol update, you can go to the BREMS webpage. We have some slideshows there that are useful. We also have on our the YouTube page for Alabama EMS Challenge, the protocol update there you can watch as well. Remember, for the EMTs, the blind insertion devices, the CPAP, the BiPAP, for the medics with the chest decompression, these are skills that you got to practice and understand before you use in the field. So you can't watch a video and then do it. All right, get with the offline medical director. Your training officer, get help with that. If you do not have an offline medical director, you need one. The times are changing. All right, new drugs to the region, new procedures, new things are coming out. You need help with that. If you're a non-transport and you need medical direction, reach out to me in the BREMS region. I'm happy to help with you. If you're a transporting agency and you want help, I can help you. I can find somebody to do that, but you need an active medical director. Okay. Cadaver lab, we canceled the one in March. I have one tentatively scheduled for September. However, it looks like that's probably going to fall through as well with the COVID. My thoughts here is I may be able to get a few folks in for one day. I'm going to send an email out soon to the area fire chiefs and EMS officers and try to get one or two people from each agency out there to do that. But I'm not going to have a mass group there this year at this point. Remember system entry. Early STEMI entry, trauma entry, and stroke, so we get you to the direct hospital. Wall times are going back up. We have a lot of boarding issues, a lot of cleaning issues due to COVID. So early system entry is paramount right now. All right. Quick review. I want to mention ketamine. Remember ketamine. We talk about this every time using ideal body weight. If you have difficulty doing the ideal body weight formula, cut your ketamine dose in half. That's a safe way to do it. But more importantly, remember, post-ketamine use, these patients are now critical. You cannot just let them lay there, all right? They need to be exposed. You look for life threats, for patches, for holes. You get an AccuCheck, they get on monitor, all right? If they become hypoxic, we do not just add oxygen to these people. We manage their airway. Ketamine causes hypoxia because of lack of respiratory drive. So we cannot just do oxygen. Basic airway management, jaw thrust, nasal trumpet. If that fixes them, high five your partner, call it a good day. If it doesn't fix them, then you assist ventilations with oxygen. You cannot put just oxygen on these people. They will have problems with that. Remember, we all know about passive oxygenation now. People can get great SATs with minimal respiratory effort if you have O2 on them. So don't hurt people with your ketamine. The other thing I wanted to mention was spinal motion restriction. I have some questions about that. People reached out to me. Remember, the short version for this is long backboards are great for extrication, getting somebody out of the vehicle, down the steps, into the truck. They do not need to stay on the board unless they have blunt trauma and signs of paralysis. So car wreck dude, you cut him out of the car, you get him onto the board, you start moving, he can't feel his legs. He stays on the board. He has a C-collar. He's strapped to the board old school for spinal motion restriction, right? Same guy or different patient. You cut him out of the car, you give him the board, you get him out. He's cussing, he's complaining, he's got back pain, but he's moving everything. You can roll him off that board and put him on your stretcher, okay? He may still need a C-collar, but does not need that backboard. Now, if you're using the backboard to help move somebody into the ambulance, they're obtunded, they're altered, you're having to manage the airway, do things like that. You don't have time to get them off the board, no harm, no foul. But we're not using long backboards for spinal motion restriction, and unless they have signs of paralysis. That is the key. Some places you go to, some hospitals, the docs will fuss at you, okay? That's okay. You just smile, refer them to the protocols, or refer them to me, and we'll take care of that, all right?
Oh, yeah? That's great. I think these are big.
Oh, yeah.
All right, 12 leads. We're going to talk about 12 leads. I like to keep these fairly simple. A 12 lead is a screening tool. I look at the ventricular rate. I say, is it too fast, too slow, or okay-ish? All right, you got to know a way to calculate your rate. If you've been here before, I've showed this numerous times. The machine gives you a decent rate sometimes, but sometimes it does not correlate. You want to put your hand on the pulse, make sure it correlates, make sure it's regular or irregular. And then when you print off your 12 lead that you're going to read and interpret, you got to have a way to interpret the rate. And I use the box method. So 300, 150, 100, and work my way through there, okay? When I get to about the 7 box, I know it's way too slow, and I'm also starting to think about something else. My ADHD is kicked in, all right? But have a method of how you're going to calculate rate on the paper as well. Intervals, you got to know your PR interval, you got to know your QRS and your QT. PR interval, really only useful to give you some data in case your patient is hyperkalemic, because first 3 heart blocks aren't super scary, but hyperkalemia is. QRS, you got to know, because that kind of determines whether you got a Vtach or an SVT, right? And then QT interval is very important, especially in patients who have syncopies or have antipsychotic drugs or certain cardiac medications. So these things, you got to know these things cold, guys. All right, so too fast, too slow, or okay? The rate. Okay. Oh, this is great voices. I like that. Right. So rate's okay, right? All right. So the next thing I'm going to do is I'm going to look for my injury patterns. All right. So I'm going to look at leads 1, AVL, and 5 and 6. These are my lateral leads. I'm going to look for ST elevation, which will be concerning for a STEMI if I have in 2 of these, or ST depression. All right. The next place I'm going to look is inferior, 2, 3, and AVF. Same thing. I got to have ST elevation in 2 separate leads to be a STEMI. Next place I'm going to look is I'm going to look at V1 through V4. I'm looking for elevation, which will be a septal or anterior. These are our septal leads here. These are anterior leads for ST elevation. Next thing I'm going to do is I'm going to kind of change my thought pattern. I'm looking for ST depression. So ST depression, T-wave inversion in V1 through V4 is concerning for a posterior MI, especially in V2 through V4. Next place I'm going to look is lead AVR. We used to think that AVR was only useful to determine lead placement. If you're up in 1 and down in AVR, your leads are on correctly. In reality, though, ST elevation will lead AVR and depression anywhere else in an injury pattern. 1 AVL, a lateral, 2, 3, and AVF is really concerning for a proximal left main lesion, a big STEMI. It's a STEMI equivalent and should be evaluated and investigated. Am I talking fast enough? Good. All right. No smiles. I like it. Great. This is just a schematic I got off Dr. Google. It kind of shows the patho of this. So circumflex is lateral leads, you can see. RCA is your inferior. And LAD is the septal and anterior. And if you think about it, both of the big coronary vessels come off nearly aorta. All right, so that's why AVR is very important. All right, so first case, 62-year-old male, dispatched for weak, nauseous. He had 1 bout of emesis, and now it's pretty sweaty. So what are we going to do for this guy? 12 lead, right? It's a 12 lead class. I like that. Smart guy. Sweet. Yeah. So if you think about our protocols, which are kind of like a rule book or a guideline, it talks about chest pain or suspected ACS. All right. So suspected acute coronary syndrome can be nausea, vomiting, weakness, diaphoresis, shortness of breath, all right, indigestion, belly pain, lots of things in the right patient population. So somebody 62 that's nauseous and vomiting, you always got to think ACS. Now, it could have been his Taco Bell or Captain D's, but don't really care about that because that's not going to kill you, all right, but it could be ACS. Sweet. All right, so we're going to do a history and physical as we're getting our ABCs. We try to teach in med school and residence. We get our history and then do our physical exam. In the ER and in pre-hospital ward, we do it all at the same time. So I'm going to approach the patient, introduce myself, handle the pulse, start getting appropriate history. As my partner puts them on the 12 lead, we're getting IV access, checking an AccuCheck, and getting a set of vital signs. So this guy's blood pressure is 115. He's breathing about 18 times a minute. He is not hypoxic, heart rate in the 60s to 70s. All right. He's a little bit diaphoretic. He looks uncomfortable. All right. Past medical history that matters. I don't really care if he's on 4 or 5 antihypertension medicines, if he's on CoQ10 or vitamins. Things we're concerned about here, things we want to figure out, is he at risk for coronary artery disease at this point in the game? So history of heart attacks or strokes. Is he a diabetic? If he's a diabetic, does he take shots or pills? Keep it simple, right? If he takes shots, we assume it's insulin, and it puts him in a higher risk category. I'm going to get this 12 lead a little bit faster if I can. Medicines that matter, obviously, if he's on Viagra, we're going to avoid giving this dude nitro. All right, if he's having chest pain, blood thinners are very important. It makes them, one, it tells you they have significant heart disease or cardiovascular disease, and two, they're at risk for injury from falls and so forth. And then drug use, cocaine, things like that really are pertinent, right? So we've got our history. This is our 12 lead. Too fast, too slow, or okay. Okay, good. Somebody sounds really excited. I can't tell who's talking though. All right, so the rate is okay, right? So what is the rate? I say it's 300, 150, 100, 90, 70, don't really care, right? So it's about 70 or 80 is the rate. All right, so next thing I'm gonna do is look at injury patterns. So I'm looking at lead 1, AVL, and lateral 5 and 6. What do we see there? Anything concerning? Yes, no, maybe? No, nothing super scary, right? Maybe a little bit of ST depression, but nothing super scary. Nothing makes me get excited about this guy. Next thing I'm gonna look at is leads 2, 3, and AVF. What did I see there? A little bit of elevation, I agree, yeah, so about 1 millimeter, so it's pretty concerning. All right, this makes me uncomfortable. This maybe, it's not a full box, but it catches my eye, right? Next thing I'm gonna look is V1 through V4. Right, so somebody already said it, depression, right? So I kind of go straight to that when we first look at the 12 lead, okay? So I got some pretty significant depression here. So this is very concerning for a posterior infarct. So this is a STEMI, all right? Machine may or might not read this. Machines are not great with these, all right? In the textbooks, they talk about you can put posterior 12 leads on the guy. You can take the B3, 4, and 5 off, move them around to the backside, look at the backside of the heart. That's way too fancy, way too academic. This is enough to put them in a STEMI system. This is enough to get them to the cath lab. This is diagnostic. This is a posterior infarct, okay? Now, because there's some days I've worked way too long and I'm tired, I'm still gonna do the same process. I've looked V1 through V4. I'm gonna go back at AVR. It looks fine, all right? I'm gonna look at my intervals. I got a PR interval. My QT looks fine. My QRS is reasonable. And then before I put this down, I'm gonna look one more time to make sure I'm not missing something. 1, AVL, 5 and 6, 2, 3, and AVF, V1 through V4. I still agree this is a posterior infarct. So this is a posterior STEMI. Cool. So what are we gonna do for this guy now? Yeah, so first thing we gotta do is we need to go ahead, we're on scene, we got this. Somebody's gonna be calling TCC, right? Put them in the system. All right, the first thing the operator's gonna say, does it say STEMI up top? If it does, you win, right? If it doesn't, you say it does not say STEMI, but I want to be patched into a STEMI hospital, and then put them, and the doc can put them in the system for you, okay? They should do that. You should transmit through your EKG if you can. If not, we all have cell phones, right? But try to send it in through your 12-lead EKG machine. All right, so we're in the STEMI system. What are we gonna do patient care-wise for this guy? Perfect. Yeah, blood pressure is 115 over 60. So how are you going to manage the nitro? What are you going to do for this guy before you give him nitro? IV fluids, right. Yeah. So I still like the old mnemonic Mona. I remember that one from years ago, right? All right, somebody mentioned aspirin. Aspirin is paramount. It's the first thing we should try to get in this guy. He is nauseous low, so you may have to hit him with a little bit of Zofran, all right? We already looked at his EKG. His QT interval is fine, so he can get a little bit of Zofran and then pop him some aspirin. Remember, what aspirin does is it makes these platelets not stick together. The body's response to having a big STEMI is to send cells to where that clot is to try to fix it. But in reality, what it does, it makes the clot bigger and causes more damage. Aspirin prevents that. Okay, it improves downstream perfusion. Aspirin, very important. You mentioned nitro. I would give him IV fluids. Hit him with a nitro. It's gonna make this vessel get bigger, which gives you more downstream perfusion. Very reasonable, right? All right, what about morphine? What does morphine do? Yeah, yeah, two things. So vasodilatation is the big thing in cardiac patients. This vessel gets bigger, it lowers blood pressure, and it also makes them kind of forget they're having chest pain, a little bit of high, right? Perfect. Exactly, right. Now, what if you give this dude a nitro, can't say dude, what if you give this patient a nitro and his blood pressure is now 90/60 with a heart rate of 90? Are you going to hit him with morphine? Probably not, okay? Some people talk about doing FONA, which is fentanyl. It's semi-reasonable. I would probably make sure that I'm doing other things first, like aspirin, second IV, make sure he's in the STEMI system before I hit him with some fentanyl, but it's reasonable. There is no indication for Kona or ketamine on this dude, right? No indication whatsoever for ketamine on this guy. What about oxygen? 97% American Heart says no, right? If you've heard me talk before, I'm a very big proponent of giving pre-oxygenation in STEMI patients. If he's having just chest pain with a normal EKG, normal SATs, does not need oxygen. If he's having a STEMI, I put a couple of liters nasal cannula on him, and the rationale for that is if you're in the back of the box by yourself and he goes into cardiac arrest, you can crank that up to 6, 8 or flush flow. All right, now you got passive oxygenation, so you can start your CPR, call for help, okay? There's limited data that shows there's a risk for giving somebody O2 for 45, 50 minutes, couple hours in the pre-hospital environment, okay? Now, that doesn't mean every chest pain gets it, but every STEMI should get it, my opinion. Sweet. So we talked about oxygen. The other thing these guys need is Vfib pads. The biggest risk of death in the first couple of minutes to hours of STEMIs is dysrhythmias, whether it be Vtach, Vfib, or some kind of big heart block that causes cardiovascular instability. So Vfib pads. Again, you can't put Vfib pads on every chest pain. You'll lose your job, right? They cost too much money. But STEMIs, they get it. Questions, comments, statements within reason. Sweet. The other thing we got to think about is in the back of the protocol book, there is this STEMI checklist that in theory we're supposed to be filling out on every STEMI patient, and I know everybody does it, right? And you turn it in. But in reality, guys, you should be asking these questions. These are very important questions to ask. And the reason being, if the guy goes into cardiac arrest en route with you, you get ROSC, you bring him to me, and he's unstable, and I can't get him to the cath lab quickly, I'm going to want to lyse him, because if he's having a STEMI and goes into Vfib, I know what the cause of that is, right? It's that big STEMI. But if I don't know his previous history, there's a risk. If you know he just had brain surgery 4 days ago, then I know there's no way in crap I'm going to give him a thrombolytic, because I'm going to kill him with that thrombolytic, right? I'm going to do other things, maybe get him to ECMO, maybe get him to the cath lab, do something different. So I'd recommend you review this. These are the questions you want to know, the data you want to get. As long as you ask the questions and you give this information to the physician taking care of the STEMI patient, you're fine, in my opinion. All right? All right, so this dude en route is sitting there talking. Chest pain was better, still a little bit nauseous after his nitro and his aspirin and his morphine. And you see this on the monitor. Normal or abnormal? Right, makes you kind of grin. You get to do something cool, right? What rhythm is this? Vtach, right, yeah. So the rate, 300, Y complex, looks pretty regular. What's the first thing you're gonna do when you see this on the monitor? Yeah. Hey, sir, are you okay? Reach over, put your finger on the carotid pulse, see what's going on, right? Because it changes management, right? So American Heart talks about stability on these rhythms, right? Stable or unstable Vtach. And I would say stability is kind of relative. If they have a pulse, that's the question, right? So American Heart talks about chest pain, hypotension, all those things, all right? So this guy is got a pulse. He's talking to you, but now he's ashen. He's diaphoretic. You cycle your blood pressure is like 70, and he's kind of mumbling. What are you going to do for this guy? Right. Cardioversion, very good, right. There's a difference. Defibrillation is just cold shock. All you got to do is have the pads on him, all right, or your paddles. For cardioversion, what do you got to do different? You got to synchronize it. And the other mistake I see people make is they forget to put the leads on the patient as well. You got to have your leads and your Vfib pads, okay? Sync it and go from there. What about sedation for this guy? Blood pressure of 70, confused. No, he's self-sedated. He's hypotensive. His brain's already not going to remember a lot of this. He's going to die soon if you don't fix it. So synchronized cardioversion. Sweet. There's some drugs that we can give. Amiodarone came into play in the early 2000s, actually late 90s, and it was a drug of choice for every kind of dysrhythmia, tachydysrhythmia. There were some case studies that it would cardiovert Vtach on its own. But in reality, you really want electricity for this guy. You can also use lidocaine. All right, old school works pretty good. I think the price of amiodarone is pretty cheap. Do most people carry amiodarone? We carry both here, don't we? We do. Okay, yeah. So I'm an either or kind of guy. Some people advocate amio. If it doesn't work, go to lidocaine. I don't really recommend that. I would say that if you're using one of these drugs and it doesn't work, electricity should be your second drug, or really should be your first drug. All right. So there was my humor that I kind of blew with the crazy cat lady. But remember, when you sync, you got to have the candles on. All right. And remember, when you cardiovert somebody, that when you clear the patient and you hit the button, sometimes it takes a few seconds for it to fire. So the guys in the truck with you need to make sure they're not going to reach over and do something different, right? Cool. All right. So this was a 38-year-old male that was called by a family for unresponsive. Basically, the story was he was in bed, had some snorts, respirations, fell out of bed. Family checked the pulse. He had no pulse. Started bystander CPR. First responders got on scene. And this is what they saw on the monitor. Yeah. So normal or abnormal? Abnormal. So what are you going to do for this guy? What are the priorities? Perfect. So he needs high quality CPR. Y'all take over the CPR. Okay. He needs IV access. If it's a difficult IV stick, what do? Drilling, right? Drilling. You can do a quick epi, a couple of grams of magnesium, and he still needs electricity, right? He needs defibrillation, not cardioversion. Wonderful. All right. So the two big causes of Vfib or Vtach, one you want to think about is you want to think about ischemia, so STEMIs, all right? So you lack blood flow going downstream, jacks up the conduction system, and they go into Vtach or Vfib, all right? The other one is structural heart disease. So people with congestive heart failure, the heart doesn't work well, so the heart gets bigger and bigger. It grows. As it grows, if you think about it kind of in a redneck way, it stretches the vessels, the things that conduct electricity through the heart, and it makes them more prone to go into Vtach or Vfib, okay? Of the two, these guys respond better to electricity and medicines, all right, because there's no ischemic tissue there, right? It's just a dysrhythmia. But those are the two main causes that I can think of Vtach or Vfib. All right, I got a few more minutes, and we're going to take a quick break. Let Dr. Schweinitz talk. But I wanted to give a couple of shout outs. This EKG, too fast, too slow, or okay? Too fast. I agree. Heart rate's machine says 140. So I got, find an easy box, 300, 150. Yeah, so I agree. It's about that rate. All right. So rate's a little bit too fast. Next question we say, is it narrow or wide complex QRS? Narrow, right? So the next question will be, is it regular or irregular? I hear mumblings. Regular? Yeah. Yeah. How do you determine regularity on a patient? Check a pulse. Yeah, so you got an irregular pulse. This looks like AFib with RVR to me. All right, I see a bunch of cool looking little wavy lines down here as well, and it looks pretty irregular. So the next question would be, are they hemodynamically stable or not, right? So altered mental status, low blood pressure. All right. However, if that's the case, if they're not altered, blood pressure is fine, I'm still going to go and look at injury patterns, right? So I'm going to look at leads 1, AVL, and 5 and 6. I'm going to look at 2, 3, and AVF. Then I'm going to look V1 through V4. And then I'll look AVR. Then I'm going to go back again and look at my intervals, my QRS, my QT. But what do we see V1 through V4? Right. Is that concerning? Yes. Normally I say that rate control comes over any other kind of interpretation. However, this one's pretty obvious, right? So this is AFib RVR with big ST elevation. This makes me very uncomfortable, right? So this is still a STEMI, even though we're AFib RVR. You could. Now, you're still going to need to go ahead and think about your STEMI care, right? So if patient is able to take PO, they get aspirin, they can get IV fluids, probably get some nitro, all right? But yes, diltiazem, you can give it. The problem with DILT in pre-hospital is what? it's got to be refrigerated. So if you have an agency that's doing expanded scope or tough to buy a bunch of that medicine and then it's sit in the back of the ambulance and go bad on you. So this was actually a patient that was a post-arrest 12 lead. This was a good call I wanted to mention out. This was, I want to say it's Summerton Fire, and I could be saying that wrong. I'll get the official name of that next time, but with Summerton Fire and RPS, it was a patient that had a STEMI, went into cardiac arrest, and they actually worked it. So patient got the appropriate medications, they got defibrillation, they intubated, a couple rounds of CPR, defibrillated back, and they were shocked into this rhythm. So this is a post-arrest 12 lead. So they're probably AFib RVR because they just had a big stress to the body, which is cardiac arrest, right? So they're tachycardic, but you can see the big freaking injury pattern still there, right? So if you think about, we've talked for years now about trying to integrate pre-hospital healthcare records and EMS, and that's come into play with cardiology now. So for years, we've done door to EKG in the hospital. We have 10 minutes, door to cath lab, we have 90 minutes. They have now pushed that out to EMS, all right? So our goal now is first medical contact, which is you guys, to balloon up is 90 minutes. And that's crazy times, right? So cardiology is pulling these numbers, pulling these charts, looking at this. It's gonna be a great win for us in the near future. Currently UAB is the only one doing it because we're trying to be a primary heart attack center. Other hospitals are following suit real quick, all right? So we got first medical contact to EKG is 40 minutes. However, when you need CPR and defibrillation and intubation, that doesn't really count, right? You gotta save the patient first. But EKG to being sent to TCC is 3 minutes, all right? The STEMI alert, we activated this before they got to the hospital. So that means they called in and said, hey, I got this guy that's post-cardiac arrest, big freaking STEMI, already sent it to TCC. That gives the hospital time to get the cardiology team at bedside and get the cath lab ready. So you can see once the patient got to the hospital, all right, it took us 44 minutes to get to the cath lab, all right? If this is at 2 o'clock in the morning, that is magical times to get that patient in there. Time is muscle, it's not a joke, it's the real thing. So this is very important. So this is a great win by Summerton Fire and RPS. And I want to stress this because, you know, the things that we're doing make a big difference, all right? If we don't get that 12 lead, if we don't do a good job with managing the cardiac arrest, these people die. But now we got somebody that had a 40-minute cardiac arrest event, all right, pre-alerted, went to the cath lab, and has a good chance of survival with this, all right?
Hey, Doc.
Yes, sir.
So we got a comment online to please remind everybody that early transmission of the ECG before calling TCC is best. That way TCC can get in front of the doc, while putting the EMS on the phone with the doctor.
Sounds great. Yes. So this is that patient's cath report. So they had a mid-LAD lesion. You can see here, the dye's not going down, so this part of the heart is not getting blood supply. They put a balloon, blow that up, put a stent in there, and look at that. Much, much better, right? I think I got it. So if you think about anatomically, LAD, all right, is V1 through V4, and that's what we saw on that 12 lead. Big ST elevations, V1 through V4, mid-LAD, which is septal anterior issues. Fantastic save by, if I'm saying it right, Summerton Fire and RPS. Sweet. The other case that I mentioned earlier, that 38-year-old that was in Vfib, torsades, was Gardendale Fire. It was a 38-year-old male on July 4th that they arrived. Patient was in Vfib. They did great pit crew CPR. Patient was intubated, defibrillated. They got ROSC. When he got to me, he was posturing. I just assumed he had a big anoxic head injury, right? All right, from a long time downtime. Short version is UAB has a hypothermia program. They chilled the guy. 2 days later, they were able to extubate him, and he's walkie-talkie, awake, alert, alive. I guess I can't say walkie-talkie. But the point of that is, guy's neurologically intact, and he was 38 years old. So that is a freaking fantastic save. So great job of Gardendale Fire as well. RPS transported that guy. Gardendale helped out, but Gardendale ran the code up front. So this is fantastic work. So if you've been here before, you've seen these slides. Original concepts of paramedicine was 3-lead dysrhythmia recognition. Years ago, all we could do is if you had a heart attack and went into a heart block, we paced you and put a pacer in. If you had Vfib, we shocked you and gave you medicines. We can do a lot more than that. We have cath labs, we have medicines, we can do other things. We can help bad heart failure now. So we got to be able to read 12 leads, to interpret these, and get the patient to the right hospital as fast as we can to manage them. All right, that's Chief Ward's favorite slide. I keep it on there just for him. Remember, these first medical contact to EKG is coming up. We're looking at that. First medical contact to transmission of 12 lead, and then first medical contact to balloon or catheter is being monitored now. So there's a lot of more eyes on your documentation and your care, which is really good. That means the hospital are getting interested in what we're doing, and we're going to have some integration of healthcare records soon. Questions, comments, statements within reason. That was pretty quick, but I want to give Dr. Von Schweinitz some extra time this morning. Questions, comments, statements. Anybody? Anything on the internet, Chief?
No, we're all caught up.
All right.
All right, we good to go? All right, so hey, I'm Benjamin von Schweinitz. I work with Dr. Ferguson at UAB. I'm one of the assistant professors there in the department. My background before this was in Air Force Special Operations, coming from San Antonio. I've been here though for the past 5 years now, and 1 year with UAB. So yeah, the people already said, so most people just say Vaughn for short. I was blessed with this long last name. It made first grade really fun. For those of you who got extra credit on your spelling test for spelling your name right, I always miss that. So, but you know, it works. So anyways, this is while we're doing this today is just to go over helping you guys out in the field get better pre-hospital care. And so if you look at the continuum of care, and especially from the military background, is most of our interventions that we've had over the past 10 years have all been prior to the patient getting to a medical center or things like that. And that's where we've seen the best success in terms of lives saved. And that's, I think, can translate well into the civilian side as well. As the better, more advanced care we can push out into the field, the better successes we're going to have in patient outcomes. Same thing about emailing to get credit. So we're going to do abdominal emergencies today. Really, there's some pitfalls with abdominal emergencies because, like I tell my patients, I don't have x-ray vision. I can't see what's going on inside your belly. We do have ultrasound machines, but for the most part, it's not going to be as obvious as something sticking out of their belly as far as why their abdominal pain is hurting. There's a lot of bad things, and there's a lot of not bad things that can cause terrible abdominal pain. But first, I want to talk to you guys about so my background in tactical medicine. I want to make sure I want to hit on this again is pre-hospital care use of tourniquets. It's near and dear to my heart. Here's this is the old one, but not much has changed between this one and the 2021. And I want you to, so this is all the tourniquet care comes from the amputation one, and basically there was not a specific one just on bleeding. If bleeding, and here it says if bleeding cannot be controlled by direct pressure, elevation, a tourniquet should be applied. I would say, in my experience, it's always been, I will put the tourniquet on first and then find another way to control the bleeding after that. I know you guys have to follow this, but if you see something with an incomplete partial amputation of a leg or an extremity, you're not going to get a pressure dressing to control that bleeding. So go ahead and place the tourniquet. And I would argue, and the Rangers agree with me, that if in most extremity severe bleeding scenarios, you probably already need 2 tourniquets to control that bleeding. So especially if you have a patient that you're entering into the trauma EMS system, by definition, whatever injury they had is severe enough at this point that they probably need a tourniquet on whatever is bleeding. Yeah, 2 tourniquets. Yes.
You said
2 tourniquets. Yeah. So up front, they're putting, so Ranger Battalion had sent out that they up front, they are putting on 2 tourniquets for lower extremity, mainly lower extremity, but most of them will do it for upper extremity too. Like there is no like put 1 tourniquet on, assess effectiveness. It is just put 2 tourniquets on up front. So just close together. So what you're doing is With tourniquets, you don't space them out. You kind of put them close together. The reason we're putting them close together is you're increasing that. So the tourniquet's about a 2.5 inch wide band. So what I do, I increase the surface area that I'm applying pressure over the artery and the vein to compress off, flow down, and basically shut off flow that way. Because we noticed that on for really strong, guys that do a lot, that don't skip leg day, or girls that don't skip leg day, you can get a lot of muscle in there, and it's going to be very hard to get enough pressure with one tourniquet down on that. So that's why they just go ahead and just go straight. Like, don't wait to see if it starts bleeding. You just go ahead and put 2 on and be done with it, and then you can move on to the next, whatever else you need to fix on the patient in order to get them to the ER. So
they're going to both of them high and tight, not 1, 2 inches above the wound, not the other one high and tight.
2 high and tight. Up front, 2 high and tight. So 2 high and tight, move on to the next problem with the patient, and then transport them to the ER. Will we move them around? Probably. But when they first, all you're going to see is a bloody mess. So until you get good exposure, you cut them completely. Most of these injuries are happening at night under low light situations. All you see is blood everywhere. You don't know if they have 2 wounds, or if I'm just seeing the 1 wound to below the knee and I'm missing the wound that's high in the back of the thigh. So that's why I say just put two tourniquets on high, as high as you can, and then move on. You've got 6 hours after that tourniquet's put on to deal with moving it down low or putting a pressure dressing on, things like that. If you're in the field for 6 hours with these patients, we have there's other bad things that happen, like your truck's broken down, you're in the wilderness medicine, and so in general for most city civilian trauma systems, just put 2 high tourniquets on, move on to whatever else you have to do to take care of that patient, get them in the truck and get them to the hospital. So anyways, and this is the second page of the amputation thing. So if bleeding can be controlled, tourniquet, like I said, I've already harped on that one. If you have an incomplete or complete amputation, I would go to tourniquet first, in my opinion. And if the bleeding is severe, consider TXA. Are you guys trucks carrying TXA pre-hospital? Probably nobody's really doing that yet. Oh, you are. So we've kind of had it now to where we're going. UAB has some data that suggests that instead of the 1 gram over 10 minutes, we're doing 2 grams over the same time frame. Again, if you get 1 gram in, great. I still see too many patients coming into the trauma bay that don't even have a tourniquet on, a bleeding injury. So if you can even get that done first, but that's icing on the cake if you can get that TXA in over the first 4 hours of seeing a patient. So that's not as crucial, but again, it's also part of helping stop that cascade of bleeding, and which gets you more and more bleeding. So these are the common ones. I think everybody's probably most likely carrying the CAT, some generation of the CAT tourniquet. You'll notice that all of the new 7th generation above, the older ones you might see out there have the 2, like you have to loop it twice to pull it through. They've kind of gone away with that now, and they just have the 1 to pull through. This is the soft tube wide. It's got a metal, but it kind of works the same way. The rat tourniquet's another one. It's probably better for pediatrics and if you're doing some canine stuff as well, because you get concentric bands. These don't, because of there's some limitations on how tight these can squeeze. Probably not as good for pediatric patients. I will tell you though, most of you guys probably have one of these in your truck, hopefully. You can blow this up and take a pair of hemostats, clamp it, and now you've got a great tourniquet right there that's probably bigger and wider than all of these put together. So that's another thing you can use. And this is probably more comfortable for the patient. It kind of gives you the surface area is a little bit wider to transport. It's not as durable. Obviously, this tubing, you can cut it, tear it if you're trying to move a patient in and out of a building or do a doorway and it gets caught. So these are obviously smaller, easier to pack. So, but those are your different options to get pressure above the wound in order to stop bleeding. Again, kind of where we're going for. Again, you first come on scene, you see a bloody mess in a leg or an arm, just put 2 tourniquets high and move on, okay? Don't sit there and second guess yourself and go, that's when you're driving in the truck and you've got an hour, if you've got over an hour transport, you can look at doing something else. But in general, put them on, get the patient in the vehicle and get driving. So, so don't be fooled. I've heard this a lot of times. Oh, it just wasn't bleeding that much when I saw them. Well, either they've already lost a lot of blood and it's on the ground, that's why they're not bleeding that much, or it's very early. And so most people, when you sever an artery or sever major vessels, those vessels are going to constrict. Okay, and you've got about 5 to 7 minutes, depending on what past medical history they have, on how long that constriction will last. And after that time, it's especially the arteries have muscles surrounding them. Those muscles will tire out, and you'll see that dilation. Now you'll see like the floodworks open up. So don't be fooled. If it's an amputation, it will start bleeding at some point. It may have already happened and you missed it, or because whatever, it took forever to get there, or it just hasn't happened yet. If it hurts, I must have done it wrong. These things are going to hurt when you put them on a patient. That doesn't mean you're doing it wrong, okay? The other one is, well, we didn't really have that far to go between point A and point B. We were right out, we were 5 minutes away. I've never seen a EMS ride that took less than 5 minutes by the time you got a call from going to see the patient, getting them packaged up. And well, it just wasn't that far, so we just figured we'd just deal with it when we got there. Go ahead and put that on, okay? And then consider putting a second tourniquet on, okay? And then, like I said, some of the groups out there are just going straight to 2 tourniquets. I'm fine if you I'd prefer you just at least get 1 on, okay? If you get 2 on, great, okay? You're not going to cause additional, these don't cause more damage by putting 2 tourniquets on versus 1, all right? So those are kind of some of the things I've seen when they come in, like, why did, you had this, why didn't you use it? Well, either it wasn't that bad, or that hurt the patient too much, so we took it off. If it hurts them too much and we had to take it off or whatever, they're screaming, yelling, we gave them fentanyl at doc, it still didn't work, then switch over to the blood pressure cuff option. I've never seen a blood pressure cuff blown up cause that much discomfort. So that's another option you have in your tool bag in order to still provide pressure without really causing too much discomfort.
Hey, Doc, could you address, and you may be coming to
Yeah,
it, but, could you address the choice between tourniquet and hemostatic agent? In my mind, tourniquet's the only choice for extremity, and hemostatic agent's the only choice for the transitional areas, but there seems to be some debate and a little confusion about that.
Sure, yeah, so no problem. So if you see here, if I can't get a tourniquet, my first choice is always tourniquet, and here's why I go to tourniquet over hemostatic agent. If you are going to use a hemostatic agent such as combat gauze or quick clot, I think that there's Cellox is another company out there that makes some. Those are the 2 big companies, I think. There might be some other smaller ones. If any of these products, you now tied your hands up. If you're doing this on an extremity, you have now tied your hands up for probably 5 minutes, okay? Because the manufacturer on all these say you have to place this on there, and now you have to hold pressure, okay? So you can't put this on and not follow through with those steps. It's not a magical kind of thing. I'm going to put this on there and all of a sudden, like, it's just going to absorb into the body and they're going to get some sort of thing. So you've tied your hands up now. And again, there's only usually 2, 3 of you maybe. So when there's only that many, you need you got to move on to the next step in life, okay? So if you're stuck here in this position holding pressure for a while, and now you have to pick up and move the patient to somewhere else, you're probably going to dislodge your clot or dislodge whatever thing you've done. So just go ahead and do a tourniquet. That takes 30 seconds, a minute if you're really slow, but get a tourniquet on there and then just move on. Now, where do they come in? Now, where would I use them as first line? Well, if I have an injury high up in the groin here, high up in the axilla here, that I cannot get a tourniquet above that shoulder or above that hip to control, okay? That is when I would go first line, is going to be my hemostatic agents. And that's where I'm going to create my, I'm going to take the hemostatic agent, open up the packaging, it's going to come out in like a Z-shaped fashion. Take the end of it, make a little power ball, make like a quarter or dime size or however big the hole is thing. And now I'm starting to push that into my track of bleeding, and I'm going to hold pressure behind that. Not with my fingers, but with my fist or elbow, something bigger, and hold pressure for 5 minutes. Then we're going to move on to the next step in care. So that is where I will go to tourniquets first, hemostatic agents second for all extremity injuries, unless it's in an area where I can't get a tourniquet over. Yes, sir.
Again, you may be about to go over this, but
No, go ahead.
Josh wanted me to ask about the junctional tourniquets.
Junctional tourniquets are great. They're kind of, you can get so many devices in your truck that you end up not being good at any of the devices at all. There's nothing wrong with the SANT. Like I know that there's, you have you can do the abdominal binder tourniquet. There's the croc or some other ones that you can put pressure down on here. The problem I have with some of those is that they're difficult to transport now, because unless you're doing this already in the back before they go. If you're doing this like on the field where they lay, you're kind of like, it's hard to move. Like if you have this big contraption on top of them, especially the early ones, and you have like these things you're trying to screw down onto the junctional injury. They're just, even when I deployed, we really didn't use junction. I mean, we saw a lot of junctional injuries. We never used junctional tourniquets. Our first go-to was always going to be these other agents. Okay, and then just do good wound packing and good care. I think those are kind of, if you don't have good wound packing skills, then maybe you should probably become more proficient at one of the junctional tourniquets. But I would say become a good wound packer, and that will be your first line in terms of these junctional injuries. So
Doc, can you envision an uncontrolled extremity bleed that couldn't be controlled by a properly placed tourniquet?
gosh,
Shortened amputation of the left shoulder.
yeah,
An
if you take it off,
that you can apply a tourniquet to. So below the elbow, below the knee.
well,
Can you think of an injury that?
the problem, so what I see with the below the elbow and the below the knee ones, like they're kind of like whatever, it's here, massive like missile kind of injuries through here, is that people don't recognize, they just see it, they don't see as much bleeding there. So they go, okay, well, it's not bleeding that much, so I'm not gonna use a tourniquet at all. And that's the problem I see with these, that they're not doing the tourniquet here because they just say, oh, it's not that bad.
I guess my question is, if you had a uncontrolled bleeding from trauma below the elbow or below the knee, and you properly placed a tourniquet high and tight on the limb,
You're done.
you're done. Yeah, so that's kind of a sure bet.
It's sure bet.
Whereas the hemostatic agent, to me, is not a sure bet.
It's not a sure bet.
Sometimes doesn't work on all wounds.
It's going to work as long as the patient doesn't move. So as soon as your patient starts moving, or you move your patient, you are now disrupting a bunch of clotting material and platelets and things like that you've worked for 5 minutes to try to get stopped. And guess what? Now you got to not move them, and now you got to start over. You got to revisit the cycle, and now that's delaying your time. It's creating more red blood cells on the ground, and you're increasing your need for downstream blood transfusions, your need for everything else downstream, because you went to a hemostatic agent first for an injury that could have been faster managed. The patient could have been in the ER sooner. The patient's now getting colder and everything else that you're trying to prevent for them, because you're just going to hemostatic agents before tourniquets. So, there's these other things that you can kind of make, because as soon as you move this, unless you don't have a way to move them, you're just probably out. I think a lot of people got maybe about 2006, 2007. But people were originally, when you looked at like where did tourniquets kind of come out from after OIF and OIR, was that they were using ratchet straps before any of these companies started really coming out with those. And then those companies came out with these products, and they were very successful, and when they were applied well in the field. And then we kind of got into this problem with time and distance. So we'd have these prolonged, I'm talking like 36-hour transport times to get somebody from the middle part of Africa back to someplace with advanced care. And what we were seeing is that we had put the tourniquet on up front, which is great. The problem is after 24, 36 hours, you're not reassessing your tourniquet. You're not doing kind of what we call like prolonged field care. And then all of a sudden you have a case where a person loses a leg that needlessly didn't, because the tourniquet, people blame the tourniquet, but really it was the time and distance that the tourniquet went before somebody actually readdressed that issue. That should never, I don't think that, gosh, that should happen here unless we're talking like doomsday scenarios at that point. So once we get to the doomsday scenarios in terms of you have to keep a tourniquet on for longer than 6 hours, we'll come up with a protocol for taking them down out in the field. So that's, yeah, tourniquets. So
I got a question too, just to clarify for everybody.
If they put a tourniquet on a patient in the field that's hemodynamic unstable with an extremity injury, they won't get dinged in the trauma bay, I guess is the question. So
yeah, please email this link and let me talk to whoever it is that feels that this was inappropriately done at a trauma center. And I'll be more than happy to address it with whoever it needs to get addressed with.
Yeah, I just want to stress that there's really no risk to the tourniquet.
There's no risk.
No risk, so you will not get fussed at. I know in the past, you'll get in trouble, and I think that there's more of a risk to not get in trouble, but if you're putting somebody in the trauma system because of an extremity injury.
Yeah, if you're saying this patient is a trauma patient.
You're better off with a tourniquet because you're in the trauma system, so.
Right, so if you need a tourniquet if you are putting a tourniquet on somebody with a bleeding problem, they need to be in the trauma, like those go hand in hand, like we're putting this patient in the trauma system because I have life-threatening hemorrhage that needs to go to a trauma center.
Right.
So,
Maybe some guy that just needs
so
to
the
nick him in his arm.
inverse of that that's important is, if you find yourself placed in a tourniquet in the pre-hospital setting, the patient has to go in the trauma.
It needs to go in the
Go in the trauma system.
They need to go to the trauma center.
Right.
They do not need to stop and pass go and collect $200 at a community hospital. They need to go to the trauma center.
But in TCC, right.
Right,
go to trauma.
unless you cannot control the bleeding, because they're going to die then before they get to the trauma center.
Well, I would argue that really depends.
Yeah.
That really depends.
Hey, to clarify, we're going to TCC, we'll
Call
find the
TCC.
appropriate
We will
institution for
provide,
you.
yes.
But my point is, like you said, use your tourniquets. You're not
Yeah,
in trouble for using a
We
tourniquet.
were really, I feel like every time we go out and do these like tourniquet cares, I see a lot more patients come into the ER and we high five, good job on using the tourniquet. And then we kind of stop, kind of doing that continuing education, and all of a sudden I start seeing patients show up to the trauma bay without tourniquets that clearly needed one. I'm not even talking like questionable cases. I'm talking like this patient needed multiple tourniquets, and you were doing CPR on a patient that had extremity injuries. By definition, they are a severe trauma patient that needs tourniquets because they're not bleeding, because you're having to pump on their chest, because you're trying to move blood around. You don't want that blood moving out the body.
Right.
So I've got another question for you. I've asked this question actually to several people in this lecture series, several physicians. What are your thoughts on if you had a patient with a closed femur fracture where the femur's grossly swollen, patients showing signs and symptoms of shock?
Yeah.
What's your thoughts of a tourniquet with no external bleeding?
Not beneficial, because you're bleeding into a confined space at that point. The tourniquet goes for bleeding into you're going from a confined space to an unconfined space. Eventually you're gonna tamponade that off at some point. I would say in a severely malformed femur, they need traction is going to be my first line in terms of, I'm not going to put a tourniquet even in the bay on this. What they need is actual traction on that femur to reduce that potential space. That's your answer for fixing those ones. One of the patients is going to like you a lot better because it doesn't hurt as bad, but they need traction on that obviously deformed, swollen extremity.
Okay.
So. But even if you did, say you did, say like, well, gosh, doc, it was swollen like this, so I put a tourniquet on it. You didn't cause any problems.
No harm.
There was no harm. All right. So, all right. Thank you for letting me get on my soapbox for a minute. So, what we actually came here to discuss is abdominal pain. So, that was real sexy into something not so sexy. So, all right. So, in general approach to abdominal, like we're not going to talk about really abdominal mimics of like, oh, they had abdominal pain, but really was their heart attack. We're going to talk about straight up, like you get a call, patient with abdominal pain. All right. So there's kind of two ways, two camps of thought that how I think about and interpret abdominal pain, and neither one is wrong. It's just how do you learn stuff? So some people think that in how they learned this was they kind of went over the system. So they like, well, in the abdomen is mainly my GI system. So I have my stomach, my small intestines, my large intestines, my rectum, maybe the upper part of my esophagus, and my appendix. That's kind of one system. And then you move on to your hepatobiliary system, which is your liver, your gallbladder, your pancreas. And then you have your renal system, which is your kidney, bladder, and the ureters that connect the two. Some people will include like urethra, penile and vaginal problems with that as well. Then you have your lymphatic system, which really the only big one in the stomach is the spleen. The GI tract is the spleen. Male and female, uterus, ovaries, males, testicles can all be, there's kind of so if you look at your fetal development of those reproductive tissues, the testes and the ovaries kind of came from the same spot. So they're both going to have a lot of referred pain into the abdomen. You have a lot of vascular anatomy running through your stomach, trying to get down to your legs. You have your aorta, your IVC, your mesenteric vessels going into your liver, your small intestines, your large intestines, your rectum. Those can all produce profound bleeding. And again, this is where you're kind of bleeding into a potential space that I cannot control. And then don't forget about some outside things that can cause profound abdominal pain is thyroid emergencies, metabolic emergencies such as DKA, hypercalcemia. And then, just in terms of if you're doing a system-based approach, lower lobe pneumonias can cause a lot of referred pain into the abdomen. I actually saw a patient with really bad, she tested positive for COVID-19, but she was complaining of severe right upper quadrant pain. And sure enough, by X-ray, she's like the right bottom half of her lung was just totally infected. But all her pain was not in her chest, it was in her belly. And then your cardiac mimics as well. Other people like this model of learning it. So I see a patient with abdominal pain. Where in the body is, we can divide your abdomen up into left upper, left lower, right upper, right lower, and we kind of know what kind of lives in each area. This kind of takes a little bit more of what's where, people, appendicitis, typically right lower quadrant. Some people say it starts periumbilical and then migrates down this way. If you're having a lot of right upper quadrant pain, people kind of associate that with gallbladder, liver, epigastric pain, people, is this reflux, is this pancreas? Left upper, again, the same, but mainly we think of spleen. Kind of our flanks and our lateral eyes, we kind of go to kidney stones. And then kind of lower part, we think of pelvic pathology, UTIs, and then kind of this left lower quadrant, we kind of think of diverticulitis, diverticular disease. So again, neither one is better than the other. To be honest, I kind of use a combination of both. If you're an otherwise healthy 21-year-old coming into me with abdominal pain, I'm probably going to use more of this system, where is your pain in your belly. If you are at your extremes of age, you're pediatric or you're adult, I'm probably going to use more of this system. And the reason for that is pediatric, you really can't, your belly just hurts and you're going to hurt all over and you can't tell me. The same thing if you're 75 and you have terrible diabetes, you've shot all your nerve endings in your stomach, so you can't really localize well enough to tell me which side of your body or where in your belly I need to be thinking about what organ has been damaged or is causing your discomfort. So that's kind of extremes of age. I kind of lean on the organ system approach. If you're otherwise healthy person, I will kind of use this approach. All right, so you come up to a patient, they have a chief complaint of abdominal pain. What questions, what do you need to be doing to ask them? Under the protocol, they use the PQRST algorithm, place, where in the abdomen is it? What does it feel like? Does it go anywhere? How bad is your pain? When did your pain start? Okay, so there's kind of that pertinent past medical. And then this is also key for patients that can't tell you. You're trying to rely now on their caregiver or somebody else to kind of give you this information, because now that information needs to get transported from you to the next person who is going to wind up taking care of them. So this is kind of important things to get. So past history is kind of important. Have you had trauma or surgery? So if you have your gallbladder removed, hopefully I'm not thinking that your abdominal pain is because of your gallbladder. I've more than once ultrasounded a patient who I thought had a gallbladder problem, turns to find out they don't have a gallbladder. So that's fun to find out. You know, if you've had your appendix taken out, well, your right lower quadrant pain hopefully is not due to remnants of appendicitis. Have you had, this is a kind of a good one, you know, did you just all of a sudden eat something that you normally don't eat? So did you try to overdose on a bunch of Tums or a bunch of iron tablets? Those can all cause abdominal pain, but those are managed very differently than you just had bad Taco Bell. You know, pregnancy status is also key. Are you pregnant or not and you're having abdominal pain? That's not only are you worried about pregnancies in the wrong location, such as ectopics, you're also worried about, for later term pregnancies, abruptions, impending delivery, lots of bad things can happen. Current medications, you know, and try to see, hey, I'm supposed to be on these medicines, doc, but I'm not taking them. That's always key to me. Or if I am supposed to be, I'm like, how many times do you come home and a patient goes, what medical problems do you have? Oh, I don't have any. Okay, do you take any medications? Well, I take aspirin and I take nitrates and I take Coumadin and like, well, so, but you don't have medical problems. No, I don't have medical problems. The medications fix some medical problems. And then, you know, what associated symptoms do you want to ask with their abdominal pain? You know, the important ones to think about: vomiting. You know, are you losing blood? Diarrhea, is it bloody? Urinary symptoms. That can kind of clue you in onto which organ system in this abdominal pain category is leading to their discomfort at this point. So, all right, your physical exam for this, tenderness is kind of important. Where's that tenderness? And the way you get good at doing an abdominal exam is to do lots of abdominal exams. And then you can start to differentiate, this patient has what we call a benign or a non-serious abdomen versus you're taking care of a trauma, we'll just use trauma for the example. If you have a patient has penetrating injury to their stomach, that's a great patient to do an abdominal exam because you actually get to feel what bad peritonitis feels like or what severe involuntary guarding feels like. That should then help you clue into when you're seeing a medical patient with abdominal pain. If they have that same kind of symptoms you note from your trauma patient, something very bad is going on in their abdomen. You just can't see it. You know, this thing, we also use these terms called guarding. Is it voluntary? Is in guarding? Voluntary guarding, what I think of when I think of voluntary guarding is that, hey, I'm going to push right over your appendix and then kind of tense up before you push. And voluntary guarding is, I'm going to push, I think it's your appendix, I'm going to push on the left side of your abdomen, and now after I push, you tense up. Does that make sense? That's involuntary guarding. So voluntary is I will tense up prior to your exam, and voluntary guarding is you weren't expecting to have pain there, I'm pushing there, and now I'm getting a painful response. Rigidity or peritoneal, again, for most people, especially in the EMS community, think of that trauma patient that's had severe injury to their GI system or stomach. If you feel their belly, I wish I could describe it for you, but it takes feeling multiple of these patients to know that that is what rigidity or peritoneal feels like. The term peritoneal comes from the peritoneal, one in the peritoneal cavity, but there's something called the peritoneum, which is kind of like this covering you get over your intestines. And what that covering is actually a kind of a big lymphatic system. And when you have inflammation of the say your appendix, you get this inflammatory response there, and you can become what's called peritoneal from that, which is this inflammation of that lymphatic system covering your intestines. The other thing it's kind of a good thing to know is, all right, well, you're seeing a patient with abdominal pain. Well, how does their stomach sound? Do you hear bowel sounds? Do you not hear bowel sounds? Do you hear extra bowel sounds that you normally wouldn't hear? And the way you're really going to get good at this is to listen to lots of bellies, okay? And that's what's going to help you go, okay, I hear them, or I don't hear them, or I don't hear them very well, or I do hear them a lot. Take your next overdose patient who's just overdosed on heroin or fentanyl. That is going to cause hypoactive bowel sounds, okay? Take your next patient that just had a bad GI bug and listen to their belly. They probably should have hyperactive bowel sounds. So this can kind of give you a clue into what is going on into their abdomen. Okay, is their abdominal distended? Now, I'm not talking about the distension you get after Thanksgiving dinner. I'm talking about the distension you get with, say, expanding belly anatomy, either from trauma or from liver disease That's kind of the abdominal distension I'm talking about. And then feel their belly. Do I feel any obvious pulsations? Now, with a lot of the intrinsic Alabama body armor over their abdomen, it's going to be kind of hard to feel down for a lot of these. But if you have an old person and you're feeling a lot of pulsations when you're pushing around their belly button, that should clue you in that the only thing that should be pulsating in their belly button should be their aorta. And if you can feel that through their skin, that aorta has gotten bigger, that should clue you in that something more serious is going on. And then obviously bleeding, you know, if they're bleeding here or they're bleeding out the other way, those are kind of things that this is more of a serious cause of abdominal pain. All right, so you get a call to Mr. Magoo's house. He's a 75-year-old male. He's telling you his belly hurts. He just didn't have a ride to get to the hospital. He wasn't really sure whether he should call 911 or not, but he called anyways, or his family told him to call. So you get dispatched to the scene. So what do you want to know? All right, tell me about your pain, sir. So he says, well, it kind of hurts kind of in the middle around my belly button. What does it feel like? It just feels a little weird. Does it go anywhere? Well, I kind of feel a little pain in my back, but I attributed that to my lower back pain that I always have. How bad is it? Most elderly people, especially once you get above the age 65, they'll usually say it doesn't hurt that bad. And the reason it doesn't hurt that bad is most of their nerve endings have been shot by this point, and they really can't describe it any further than that. And then how long has it been going on to? Well, it's been there since this morning. I thought it was just bad gas. They're always concerned about how many bowel movements they have. I thought it was just constipated. So they'll try to throw you off into the thinking that this is something not serious. You ask him, you know, well, have you been vomiting? Have you been having diarrhea, urinary? He says, no, no, no. You ask about his medical problems. He tells you, well, he has AFib, hypertension. He's had a heart attack before. You get some good surgical history because you listen to this course, and you notice he's had his appendix taken out at 18. He has gallbladder taken out at 40. He has a med list in his wallet that seems to be up to date for the most part. You start to assess them, you hook them up, and then you get your initial set of vital signs here. What I would caution you to is say, hey, did you take your meds today? Yeah, I took my meds today. If you're telling me you can take a beta blocker today and you can still get your heart rate over 100, that's bad. That should be one of those red flags like, wait a second. He took something to keep his heart rate low, and yet he can still generate a heart rate over 90. Something really bad is going on. You took your blood pressure medicine and your heart rate's 180 over 110. I know we see a lot of asymptomatic hypertension, but if you're telling me that I took these, it's normally well controlled, and now I'm getting blood pressure readings that high, something bad's going on. And then you examine his abdomen. You kind of walk away from your abdominal exam as, it's not that bad, you know, it's okay, you know, I'm not really, you know, but this is a patient where your abdominal exam, as I've said before, as you get older, especially with a history of, especially if you have a history of diabetes, you cannot rely on that exam to kind of go, is this something serious or something not serious? Don't get trapped into that thing. So, all right, so you do all this, you have some pain, it's kind of going to the back, kind of going to here. So what we would think about in terms of this is be interpret mind. Differential is for intra-abdominal catastrophes. I didn't put that on here. So the other thing was he had a pulsatile, but anyways, would be some sort of aortic catastrophe going on. So this guy winds up having an abdominal aortic aneurysm. So what this is basically most of these occur below the level of the kidney. So that's why you're going to, this is not fair. This is actually shift this further down a little bit. So that's why people will kind of feel right here for that pulsatile region right above the belly button, because usually right at the belly button is your iliacs kind of break off and go to either side. We can diagnose this just quick at the bedside on ultrasound. Basically what you're trying to do is measure the entire length of the wall. What you'll have when these start to rupture, start to break, is you'll start to get clot formation inside the vessel itself. So if you look at, this is probably the original size of the aorta, and the rest of this is clot that's not kind of formed around it. Well, I see people will make in the ER, people will make the mistake and they'll try to measure this and tell me their aorta is normal. And when really, in reality, you got to measure the whole aorta, including clot burden, to say how bad it is. Basically, anything above 3 centimeters is at risk for rupture at that point. So how do we fix this? What can we do pre-hospital to do this? So treatment pre-hospital is recognition, right? So if you have an old person with abdominal pain, if your mortality just telling me that you're old and abdominal pain, your mortality is around 12 to 15%. Just that's it. I mean, those two words together, old and abdominal pain, you have now increased your mortality. I'm talking new abdominal pain, not pain you've had since you're 20. New abdominal pain in your old that. So hey, what if they even tell you, hey doc, they were monitoring me for this aneurysm they wanted to see, and now all of a sudden you think it's ruptured. Some things we try to look for, you know, get on your med control, see if they want you to start trying to control that heart rate to bring it down, okay? That'll help reduce some of that force. You want to try to keep their systolic blood pressures low. Not for here, but some people, you can even try to start putting in Roboas and things like that to try to tampen out off that. So how we're going to try to fix this once they get to the hospital is we're going to call in our vascular surgeons and we're going to try to get them to the OR. Try to capture it before it ruptures. As soon as it ruptures, your mortality just went to 80%. The last one I had was a guy who went to a outside facility. They were, you know, had some abdominal pain. He was 65. They diagnosed his aneurysm. He was large but hadn't ruptured. He had about a 2-hour. I don't think there was air that night. He had about a 2-hour transport from that facility to our facility. By the time he got to our facility, his abdominal pain became a lot worse. He looked a lot worse. He had rupture. We actually did get him to the OR and were able to get it repaired. Unfortunately, even though we were able to get him to the OR, once it ruptured, he still unfortunately did not make it because once you lose that major vessel in your body, you have about, if we look at our data from trauma, once you lose that vessel and we can get something to temporize it, you have about 40 minutes to get it fixed. If you can't fix it with that 40 minutes, it's kind of game over. And these surgeries usually take hours to try to fix. So it's one of those things is that's kind of one of those time equals life or death. All right. So case number 2 is you're called to this lady's home. She's around 40. She's coming in with a chief complaint of abdominal pain. You see her, you take your Zyrtec before going into the house. And she tells you, Doc, yeah, my belly's been hurting for a while. I want to get checked out. So because you listen to this course, you ask all these questions. You say, well, tell me about your pain. She tells you, well, it's kind of in her right upper quadrant, kind of right in her epigastric region. It's sharp. Well, does it go anywhere? It goes into my shoulder blade. Well, it's pretty severe. Well, when did it start? Well, 2 hours after I had dinner. Okay. What other symptoms do you have? Well, I've thrown up twice, Doc. I didn't notice any blood. No, I hadn't had any diarrhea. No, I hadn't had any bleeding. Past medical. I always love I'm pre-diabetic or I'm pre-hypertensive. That just tells me you're just those things already ready. Have you had any surgeries? Well, I've had a C-section before, and only medication I take is Tums. So you hook her up, you do your physical exam, you get your initial vital signs here. Things that should stand out to you are her heart rate and her temperature. That is not just run-of-the-mill abdominal pain, okay? This is something bad going on. If you can have abdominal pain and you generate enough pain to have a severe fever, something very bad is happening. You palpate her abdomen, you notice she's got a lot of tenderness in the epigastric right upper quadrant. When you push on it, it makes the pain a lot worse, but she has no pain anywhere else in her belly. So you push down low, doesn't reproduce the symptoms. It's just all kind of in that right upper quadrant there. But because you go that extra step, when you saw the patient, you notice this about her eyes. They're more yellow than normal, which that plus fever and right upper quadrant pain equals this thing called ascending cholangitis or acute cholangitis. Basically what you've had happen is on ultrasound, you probably had a history of gallstones in the past. Problem is they've been really small gallstones. And when the gallstone comes out of the gallbladder, it goes through this thing called the cystic duct. The cystic duct forms with the ducts coming off the liver and the ducts coming off the pancreas. A lot of times it gets all the way almost into the duodenum, but it gets stuck right here. And when it gets stuck right here, now the fluid can't go down, so it starts to back up into the pancreas, it backs up into the liver, and it backs up into here. Well, this now becomes a great breeding ground for a bug called E. coli, which is kind of your major cause of this. And so E. coli is one of those things that can kill you rather fast, within 24 hours. So they come in, they're jaundiced, they have right upper quadrant pain, they have fever. And basically what we have to do now is try to fix this. The problem is by the time we see this, they're really sick to have a major surgical operation. So pre-hospital, what we can do for them, we can give them pain control, nausea control, IV fluids, right? So that basic, you know, the ABCs, support their breathing, start that hydration because we know they're probably already volume down from another cause, control their nausea, control their pain. At the hospital, what I'm going to do for them is start them on antibiotics. I'm going to talk to my GI docs about doing what's called an ERCP, okay? I'm not going to worry too much about the gallbladder at this point because the gallbladder, although it caused it, it's not what's going to cause them to die right this second. So basically what the GI doctors will go in, they'll go do an upper endoscopy. They'll stick a camera all the way down into here and they will find this duct. And what they'll do is they'll stick a stent or a claw, go in, either make a cut here to open that dog up called a sphincterotomy, hopefully dislodge whatever's been backing them up. They usually see like a lot of this just green kind of nasty purulence come out. And then they put a stent in to try to hold this open. A lot of times if this is on, and we'll put a stent, right? We'll put a percutaneous drain right into their gallbladder to provide some pressure relief somewhere else for this infection because we got to get this out. We don't go right in away and just take out their gallbladder and do that. The reason is because this is an inflammatory nightmare. So if you try to go in and take this, you have liver stuck to gallbladder, stuck to pancreas, and you cannot tear those apart without tearing apart their entire hepatobiliary system. And then you're going to wind up with some other bad problems. So we try to be a little bit more antibiotics, give your body a time to let this drain out, and then hopefully go back later and take out the gallbladder.
Hey, Doc, can that procedure sometimes lead to the inability to get the pancreatic enzymes? I just have a couple of friends who have had that, and they both went through long battles with not being able to produce pancreatic enzymes.
Good question. So when you get this stuck here, gallbladder disease causing pancreatitis, your pancreas makes some really awesome chemicals, lipase, amylase. Those can digest a lot of good stuff. The problem is, as long as they go in the right direction, they're going to digest the right things. As soon as that amylase, lipase kind of go in the wrong direction, they can leak out back into the pancreas. They're going to start digesting your pancreas. And so what does your pancreas make? It makes amylase, lipase, and when you don't have those two, what happens when you eat something that requires those digestive enzymes? It's just going to flow right through you. You're going to get lots of abdominal pain, lots of gas. And what we'll do is we'll actually give you oral pancreatic supplements, which are those enzymes that you're missing. The other bad thing that will happen with this is that the other big thing that this produces is insulin. So we've had bad people with bad pancreatitis that basically their pancreas stops working. Now they are type 1 diabetic. So it's very important to get, as soon as we can get this pressure relieved, and when I say relieved, this patient probably has about, once you start to getting into this fever, Charcot's triad, jaundice, probably have about 24 hours to fix this problem. Maybe less than that. I would say probably closer to 12 hours. If you can't get this relieved in 12 hours, their mortality is, again, like the ruptured abdominal aneurysm, you're looking at an 80% mortality. If you're older, probably more closer to 90%. So one of the things that you want to get fixed, you want to get it fixed soon. So.
Are there big risk factors to that? I mean, is it the same risk factors that you would see for cholecystitis?
Sure. So I kind of give the exact.
I was curious.
For this, yes. What differentiates this from just run-of-the-mill biliary colic or gallstone colic is fever and jaundice. Once you get those two things plus this, bad. If you just have biliary colic, which is every time I eat a fatty meal, I kind of hurt here, but you don't get fever, you don't get jaundice, you just have like these recurrent bouts. What's usually happened is one of two things. Which way? I'm going the wrong way. Is that you have these, they're either just stuck in your gallbladder and they can't get out, or the stones are so small that they're able to pass on through. Okay, that's when you get that intermediate sized stone that can go through the cystic duct, but can't get through the common bile duct. That's where the big problem comes in. So, and the treatment for this, if you just have this, no fever, just pain, that's an elective gallbladder removal, okay? When you have this plus fever, but you don't have the jaundice, that's acute cholecystitis, which is an infection, but the infection is now localized into the gallbladder. We can put you on antibiotics, go and take out your gallbladder, and you'll be fine. It's when you develop the jaundice in addition to that, that's when we know something more, like you've gotten something stuck here. Now it's affecting more than just the gallbladder, it's affecting the liver and the pancreas at that point. So. All right, case 3. He's a big 2-year-old. Oh, you get called to the house with a 2-year-old male with some abdominal pain, right? Great, thanks, awesome. Is there another service that can respond? So you try to do your PQRST and you get these responses, right? Cry, 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 cry. Awesome, right? Yeah, 2-year-old trying to tell you, my 2-year-old trying to tell me what's wrong with him is awesome. Actually, a good thing to do with a 2-year-old or somebody that's small is we kind of ask them, well, does your hair hurt? And that's kind of one of those things like, what's really going on? Like, it's kind of like, well, if it hurts all over and your hair hurts, then that's kind of can help you out there. But anyways, pediatric abdominal pain, again, you're dealing with extremes of age. Very old person with abdominal pain, bad. Young person with abdominal pain, bad. 2-year-old, usually when they hurt, they don't fake it. Okay, there's something serious, okay? So you talk to the mom, dad, who's ever there, babysitter, or no one, hopefully, not no one. They notice he's thrown up maybe once or twice. He hasn't really been eating anything. He just says his belly's been hurt and he keeps pointing there. He kind of just won't do anything for us. No, I haven't noticed any diarrhea. No, he hasn't been bleeding. You ask some questions. Has he had any surgeries, anything? No, no. I've given him some Tylenol and Motrin thinking that would help, and you kind of don't really get much of an answer. Well, okay, so you hook him up. You get your heart rate, your vital signs. Remember, you cannot translate adult vital signs for your pediatric patients, okay? I don't remember them. I don't remember them off the top of my head. I always use a reference, always look them up. Just don't guess and say, I think that's right, okay? Look these numbers up, okay, when you're seeing these patients. It's not something that I've chose to memorize in my life. So again, I'll use my outside brain, my cell phone, whatever, or use if you have a Broslo tape in your truck, pull that out. It usually has all the vital signs that need it for different weights, different ages. All right, so you do his abdominal exam. You notice it's soft, it's non-tender, you got normal bowel sounds. Diaper, you see it there, there's no blood coming out. However, when you do the diaper and you take a look, you notice that his scrotum swollen, it's swelling. You're like, oh, that's bad. All right, so if I saw this and I see that, my concern for a male with that is testicular torsion. So what's happened is that as your testicles move down into your scrotum, they develop these long cords that connect them back to other things. Those cords are almost like bungee jumping things. So basically what can happen is they can start this twisting motion. And when you get this twisting motion, the blood supply, the artery and the vein run through those cords. Well, if I twist it, I have now cut off your blood supply. And when I cut off your blood supply, you get dead testicle. So how often do we have to replace a dead testicle? Actually, it's the same amount of time we have with a tourniquet, 6 hours. I don't know why we came up with 6 hours, but 6 hours seems to work for a lot of different things. So we got 6 hours. So this is one of those things, time is testicle, time is ovary. You've got 6 hours to get this thing untwisted, or now they're at risk for loss. So what we're going to do for him is you're going to give pain control, nausea control. This is one of those things you have just to have a high index of suspicion, okay? This is not one of these things that the patient's going to tell you, yeah, doc, my whatever hurts. You have to think that this is going on or this is a potential problem. What's going to happen when they get to the ER? I also have to have the same high index of suspicion that something terrible is going on. What can we do is we can do what's called an open the book, which is where you try to untwist the testicle. We will do an ultrasound, and ultimately they need to have their scrotum opened up and they go in and they do what's called orchoplexy, which is where they will take a suture and tie the bottom of this to the inside of the scrotum, and that'll prevent them from twisting anymore. So even if you have it on one side, the chances of you having another side are high. So again, it's that 6-hour thing. And remember, a lot of parents, I'm gonna try. They're hurting, whatever. I mean, they cry a lot, so I'm gonna give them Motrin, I'm gonna give them Tylenol. And so that clock's already started. So we're working at a disadvantage already in getting these patients. So in order to preserve blood flow.
So got a statement and a question. Great. The statement is nobody should be twisting any testicles in the pre-hospital setting.
No. So, yes, that's why. I just told you I was thinking what is going to happen. Please not use testicles in the hospital setting.
And the question is just a curiosity. How do you know which direction to untwist?
Good question. We don't, is the short answer. But typically, we'll try both ways. But eventually, most testicles will twist internally, okay? And so why that happens, I don't know. It's because the way the Earth spins or what the deal. I don't know if in below the equator they spin the other way. But in general, they tend to twist inward, okay? So our first, that's why it's called open the book, we'll typically twist them outward towards the outsides. And guess what? If that doesn't work or it makes it worse, I'm going to twist the other way. That's how I'll know whether it's working or not.
I'm not comfortable with that certainty. Level of certainty.
So when I've done this, the actual
Both equators are long transport.
actually what it's don't twist it, don't twist. But what you actually, if you've ever known somebody or says what actually it does, it doesn't just twist up and stay like this. What it'll actually do is turn sideways like this. And so you can kind of almost, when you start to untwist it, you actually feel it drop because it's twisted, it twists up high because it's now shortened. So actually you'll feel it start, as soon as you start twisting, all of a sudden like you'll feel this like drop down phenomenon. So you don't really twist that much to know, oh my gosh, am I twisting in the right or wrong? Because you start to twist and it goes higher, you know you're twisting in the wrong direction, you just twist the other way. So. Yeah, it's not, I mean, you can use, I don't think people want to remember it. Actually, the biggest thing, so the ones I've done, it's the manual detorsion is like, it's like all of a sudden, like they feel just a ton better after that. But yeah, pre-hospital, I'm giving that. I'm usually using fentanyl for these guys' pain because I know the pain is temporary. As soon as I get it fixed, their pain's gonna go away. So, but yeah, that's a good indication for pain and nausea control, because any sort of retching or throwing up is going to put more pressure on the spermatocord and it's going to make it hurt more. So you want to try to control those symptoms as best as possible. So the two I've had have both been people in their 20s actually. One guy, we were deployed and he came in with his chief complaint was literally this. It was abdominal pain. You press on his belly, he's a 21-year-old guy, you feel all over, like, he says it hurts, but, you know, his belly looks fine. All I have is ultrasound, I don't have CT scans. And I'm like, why is this guy telling me his belly hurts and there's nothing wrong? Like, you push all over, nothing's wrong with it. And then I kind of like, well, let's do a testicular exam. And he's like, I don't know if it was a cultural barrier, he's like real hesitant. And I'm like, no, I need to take a look. And sure enough, his testicles twisted high up into his scrotum. And we were able to get it untorsed. But those have been you'll see like for your adolescent kind of, so these kind of occur in different, there's waves of these. You'll have a very high incident in young, like two-year-old men or 2-year-old boys. And then you'll have another incidence in adolescence where those will happen again. It's kind of this like bimodal distribution of when this torsion will occur. When most, the limited number of adolescents I've seen that have had this, they usually associate it with a bowel movement or with working out. For whatever reason that causes, I don't know if that causes it or they just notice it then, that's when they twist. So at least that's what they tell me. This is another thing you can see on ultrasound. You see blood flow going to this one, absent blood flow to this one. And again, that's no bueno. So again, ovaries and testicles have the same, origins. So if it, for females too, if you have a lot of nausea, vomiting, abdominal pain, a lot of deep, it's almost described as like this deep pelvic pain. That's a thing for ovarian torsion just as much as it would be for a guy with testicular torsion. So I got time. All right. So last case, 67-year-old male comes in with abdominal pain. There he is right there. The pain, he says it's achy, kind of radiates to his back, kind of moderate. It's not the worst pain he's ever had, but definitely not a walk in the park. It's been intermittent. It's been going on for days, right? So your associated symptoms, he's vomiting, just copious amounts, doc. Some of it, he says he's noticed some blood. He said it may have looked coffee ground. I don't know why people all of a sudden know that term, but somehow they just associate it with coffee grounds. Yeah, my stool's been different. They've been sticking to the side of the toilet. They've been tarry. No, I haven't had any urine symptoms. Well, what medical problems do you have? Well, I've gone through alcohol withdrawal before. I've had my appendix removal, and I've had a procedure called a TIPS procedure, which is where we go in and we create a connection between the biliary system and the IVC to help relieve pressure. And my meds, I'm on Creon, which is that pancreatic supplement you're talking about. I take aspirin, I take metoprolol. You do his vital signs. He's 80/40, heart rate 110. Again, abnormal heart rate with a beta blocker, very concerning. Temp is normal. Respiration rates are up. It's 30. He's hyperventilating. Abdominal exam, you notice he's distended. He's got tenderness to palpation almost everywhere. He's got voluntary guarding. His bowel signs are hyperactive. He's got an abnormal smell when you walk in the room. Okay, this is pretty classic for a GI bleed. Okay, the reason people can kind of pick up on the smell of a GI bleed is you get that iron from your red blood cells breaks down, and that's what causes that kind of classic smell. So the issues with this one, you can have basically a tear anyway along the way. Most of these will occur kind of in the stomach for an upper GI bleed. Basically what will happen is acid will break down the blood, and that's where you get the coffee ground kind of texture of it. And then they come back the other way again. Acid's broken it down. It's had time for absorption. You get that tarry kind of consistency from the other end. They can bleed a lot from these. They can be copious. So one of these severe life threats, you need to get somewhere fast. What can we do for them pre-hospital? These guys are at high risk for that blood and acid to go down into their stomach, giving them basically a pneumonitis or a inflammatory response in their stomach. So try to prevent that from happening. How do we do that? You can control their vomiting with IV medication. These guys are very volume down. They've been vomiting. They've been losing it through their GI tract. They need lots and lots of fluid. In the hospital, when they get to us, most of the time I would consider like a semi-elective, almost emergent kind of intubation. One, I don't want them to aspirate anymore, and I need to get control of the bleeding. How we do that with medications is we put them on a Protonix or some sort of proton pump inhibitor to help. We'll give them, if they're a cirrhotic or alcoholic, we'll also give them octreotide, which will help reduce bleeding. We'll try to get our GI docs to do early endoscopy, basically go in, cauterize, like on this previous picture, go in and cauterize and stop that bleeding. We're not as big on, and different from trauma with GI bleeds, we're not as big on blood products, okay? There's been some good studies out there that show we rather treat you with IV fluids and then transfuse you if you're basically your hemoglobin drops below 7. And they compare that to like hemoglobins above 10. We notice early blood transfusions don't really help these patients. In fact, sometimes they do worse when you give them blood early and they don't need it. Other thing you'll see here, especially you might run into this, especially if you're transporting from a small urgent care rural center to someplace a larger tertiary center with a GI. is some of these smaller centers carry these, what this is called a Blakemore tube. What it is it's a tube that has a basically a balloon dilation and an esophageal dilation. And what that does is basically you're creating a tamponade-like effect on the inside of the stomach, the inside of the esophagus, and hopefully trying to slow down or stop that bleeding. If you have one of these in, the patient's usually intubated. What can happen though is as you blow these up, they tend to slide down into the intestine. So what you have to do is actually have something to secure it so it doesn't slide further down into the body. There we go. So it doesn't slide further down into the body. So you'll see the classic thing, you'll see that this guy is wearing a football helmet with this thing tied outside in terms of trying to transport one of these. So if you do have one of these and you're transporting, just make sure it doesn't keep sliding down, okay? You can apply gentle traction with it, and you're not gonna pull it out, okay? These things are blown up, they're not gonna go anywhere. The only thing that could happen is they slide further down. So, and that's kind of a sort of temporizing measure. Yeah, so this part right here will cover your esophagus, and this one will blow up large for your stomach. The problem with these, we don't use them that much. We probably do not use them at UAB, and the reason being is that the risk of these is you can get esophageal rupture. You already have very friable, dilated esophagus anyways, and I'm about to put a lot of pressure on it. I really can't. It's hard to put in the right amount of pressure. How much do I need to put in? And you can basically get you can create a tear, and what's called Boerhaave syndrome, or basically a bad mediastinum, and now you have all your contents leaking around your mediastinum. But again, sometimes if you don't have GI specialists, you need to put one of these in to temporize them to go somewhere else. But the other problem with these is that I can't do endoscopy when this is in you. So they have to come out before that. Again, most of these patients should. I've never seen one of these put in without the patient being already intubated as well. So you're kind of dealing with two problems there. You have an intubated patient, plus you're having to manage this tube as well. Once they're blown up, I'll see them. So this comes with 3 ports. One blows up the stomach, one blows up the esophagus, and this port right here, you can use to suck out any of the GI contents. This is an open tube system. So, so again, you might see that if you're doing some transports. All right, so this is, I'm sorry, I pulled the other one, but guess what? It hasn't changed. In your protocol, we kind of already discussed the PQRST in terms of getting your history and physical. Things we kind of really want to know: blood, basically vomiting, diarrhea for volume loss. I don't really care as much about constipation. Everybody has constipation. Bleeding is kind of important. Is there urinary symptoms? Fever is a big one. Fever and abdominal pain, especially if you're catching fever early on, that's bad. Obviously, history, traumas, ingestions. We talked about medications. Any history of known disease, esophageal varices, alcoholic cirrhosis, history of pancreatic problems, surgeries. Pregnancy status is very important in these. Pregnant patients with abdominal pain, very bad. Lots of badness. And how does your abdomen feel? And you're going to get good at this just by doing a lot of abdominal exams, okay? Do them on patients that don't have abdominal pain. Do them on patients that do have abdominal pain. That's how you're going to get this, what's normal, what's abnormal, and then follow those patients up. This patient had this exam, they had this outcome, and that's how you're going to get better and better at doing your abdominal exam. Key points, lots of internal bleeding can come from that. Early entry for going to your shock protocols. Patients with dissections, aortic aneurysms, try to keep their systolic blood pressures low. This would be something, especially if you're a longer transport, consider talking to your med control about starting some sort of beta blocker or something pre-hospital if you have that ability. I don't think anybody's using nitrous oxide. I don't know why that's still in there, but anyways, don't use nitrous oxide. So again, monitor for sepsis. Be very careful for your old patient that's on beta blockers. Transport in position of comfort. Again, I tell this patients come to the ER all the time. They come in with abdominal pain. Hey doc, can I eat something? One that actually reassures me that something probably not serious is going on. But at the same time, if this is something bad, we're still going to treat you. So say you did whatever, have a Big Mac or something, and now we have to take you for emergent surgery. We're not going to say, you can't have emergent surgery because you ate a Big Mac. But what will happen is on the flip end, after you get out of your emergent surgery, now you're going to be throwing up everywhere because of the effects of the anesthesia and things like that. So that's why we tell people not to eat. It's not that we wouldn't do like if you just have a Big Mac and then walk outside and get shot, well, we're not going to wait 8 hours for you to go to the OR. We're still going to take you to the OR. The problem is we're going to have problems on the back end. So that's why we tell patients not to eat. Obviously, this is something that can change over time. And again, this is something, if you do an abdominal exam early, and then later on you do another one and you notice a change, spidey senses need to be going off, something else is well, why is this patient getting worse? Ketamine, morphine, fentanyl for pain control is great. Hopefully they'll add one day in the protocol some Haldol. Is also kind of, I like to use that now for my basically undifferentiated patient comes in with undifferentiated abdominal pain. So that's it. Thank you guys.
Awesome. Sweet. Thanks both docs today. Great lectures. Really good. Thanks for everybody that signed in online and everybody who attended in person. Had a really good attendance today. Sorry we got started a few minutes late, but it all worked out. Please remember to click the link in the chat box to fill out your attendance form. One attendance form per participant. Your certificate will be emailed to you in a few days. If you can't remember that link or you don't do it now, you can send an email to Alabama EMS challenge at gmail.com. You get an automated reply with a link to the attendance form. Dr. Ferguson, do you have any other announcements for today?
Nope.
All right.
Thank you, sir.
Awesome.
What's the password, sir?
Oh, I'm sorry. The password for today's class is abdomen. Abdomen is the password. That's in the chat box as well. What did you want it to be, Dr. Ferguson?
No,
You want
sir,
it to be
no comment.
Megadeth or something?
Yeah,
Yes, sir. Okay. So anyway, thanks everybody. Appreciate it. See you next time.
Still get a certificate up at Megadeth? Sure. You can't spell Megadeth.